Hey everyone, and welcome to this explainer. Today, we are tackling a seriously critical neurosurgical challenge, pediatric undershunting and the exact step-by-step protocol for shunt tapping. We're going to break down the etiologies, the diagnostics, and the hard clinical thresholds, all so you have a totally clear, structured roadmap for your actual practice. Okay, let's dive right into our roadmap for today. We'll start with undershunting risk, then look at biological occlusions, hardware breakage, and after that, we'll walk through the shunt tapping protocols, from checking initial flow and running diagnostics, all the way to some absolute vital warnings you cannot afford to miss.
All right, part one, undershunting risk, 17%. I really want you to think about that number for a second. That is the approximate shunt malfunction rate during just the first year of placement in pediatric patients. We're talking about nearly 1 in 5 patients experiencing a failure within 12 months. That insanely high rate is exactly why mastering the diagnostic tapping protocol isn't just good to know, it is an absolute necessity. Let's move on to part 2, etiologies, specifically looking at the causes of occlusion.
So when a blockage happens, there is rarely just one biological culprit. What's really interesting is how varied these occlusive materials can be. Proximal obstruction, for instance, can be caused by the choroid plexus itself getting in the way, or it could be a slow, steady buildup of proteinaceous secretions. But we also have to be on high alert for things like blood, inflammatory or tumor cells, and of course markers of infection. Literally any one of these can completely compromise the shunt's patency.
But anatomically speaking, where do these blockages actually happen? Well, think of it kind of like a plumbing system. Up at the ventricular end, the usual suspects are the choroid plexus, glial adhesions, or intraventricular blood. Now, as we move down to the intermediate hardware, the valves and connectors, that's where tumor cells can clog up the filters, or where surrounding tissue pressure can literally force the anti-siphon devices closed. And finally, never ever forget to check the distal end, because blockages can absolutely happen at the very bottom of the system too.
Which brings us to part 3. Hardware breakage and disconnection.
Because biology is really only half the battle here, right? Mechanically, the silicone elastomers used in these shunts calcify with age. They become rigid, they get super fragile, and they start to stick to the subcutaneous tissue. And here is a crazy piece of irony for you. Barium impregnation, which is used specifically to make the tubing visible on X-rays, can actually accelerate this physical breakdown. Also, keep a really close eye on the area near the clavicle. The continuous motion of the body right there makes it a prime hotspot for tube fractures.
All right, part 4, shunt tapping and initial flow steps. Let's get into the actual procedure.
Okay, so let's walk through the standard operating procedure. First, after a thorough shave and sterile prep, you're going to insert a 25-gauge butterfly needle right into the reservoir. Immediately, you are looking for spontaneous flow into that butterfly tubing. The diagnostic interpretation here is wonderfully straightforward. If you see spontaneous flow, it tells you the proximal end of the system is not completely occluded. It is your very first clear sign of proximal patency.
So, you've established flow. Excellent. The second action is to measure the pressure using a manometer. This reading actually reflects the pressure of the ventricular system itself. To give you your clinical baseline, a completely normal reading is less than 15 centimeters of CSF, but keep in mind that assumes you have a totally relaxed, recumbent patient.
Now, to verify the independent functionality of the distal components, you want to measure the pressure with the distal occluder compressed. So the crucial point here is that a rise in pressure is actually a great sign. It physically confirms that there is at least some function happening within the valve and that distal shunt. By isolating the distal end like this, you get a much more accurate assessment of the whole system. Moving right along to part 5, shunt tapping pressure diagnostics. Now we're getting into a classic if this, then that diagnostic tree. What if there is zero spontaneous flow? Well, your next step is to try and aspirate CSF very gently with a syringe. If that CSF comes out easily, it might simply mean the pressure seen by the ventricular system is just really low. However, if you get no CSF at all, or if it feels like you're pulling against a brick wall, that strongly indicates you're dealing with a true proximal occlusion. So what if you were still getting absolutely no flow? The protocol dictates that you carefully inject 1 to 2 milliliters of preservative-free saline into the ventricular catheter. Sometimes, this little flush is enough to dislodge a clot or some debris. But watch this closely. If only the 1 to 2 milliliters you just injected, or maybe even less, returns to you, it definitively proves that you do not have a patent catheter in an open CSF space.
Your differential now includes a completely blocked catheter, a tip firmly lodged into brain tissue, or slit ventricles.
Which brings us to our final section, Part 6, Shunt Tapping, CSF Testing, and Vital Warnings.
First, a golden rule for your practice. If you successfully aspirate CSF, do not waste it. Send it off immediately for culture, protein, glucose, and cell counts. This step is your definitive shield against missing a quiet, smoldering infection in the central nervous system, or lurking on the hardware itself. Let's move to how this builds into checking the forward transmission pressure through the valve and peritoneal catheter. Here are the exact chronological steps. Step 1. Fill the manometer with sterile saline while the valve is off. Step 2. Compress that proximal occluder. And Step 3. Open the valve and measure the runoff pressure after about 60 seconds.
When you get that runoff reading, you have to know the hard numerical limits to actually interpret it. In a normal system, the forward pressure should be less than the ventricular pressure. Furthermore, the absolute pressure reading for this specific test should be less than 8 centimeters of water. These thresholds are strictly, meticulously defined so you can confidently recognize normal physiological function versus a dangerous downstream blockage.
But what happens if you have zero distal flow during these checks? You keep that inlet occluder compressed, and you inject 3 to 5 milliliters of saline directly into the distal shunt, and then you recheck the distal runoff pressure. If you see a considerably higher pressure right after this injection, it acts as a very specific diagnostic marker. It's essentially telling you that the peritoneal catheter is likely emptying into a loculated or walled-off compartment in the abdomen, which is totally preventing proper absorption.
And this brilliantly illustrates the most vital safety warning of the entire protocol. It is an absolute, non-negotiable rule. Do not ever inject more than 1 to 2 milliliters of fluid into the ventricles. Exceeding this tiny volume carries a massive, immediate risk of dangerously spiking the patient's intracranial pressure. We're talking about severe, potentially fatal neurological damage if you get this wrong.
We've covered a lot today: the 17% failure rate, the varied biological and mechanical etiologies, and the incredibly precise step-by-step logic required to safely execute a shunt tap without missing a single critical detail. But it leaves us with a really provocative thought. Given these incredibly high malfunction rates and the frankly risky diagnostic thresholds required to check them, how might future neurosurgical hardware designs evolve to completely eliminate the need for manual tapping altogether? It's something to think about. Thanks for joining me on this explainer, and keep questioning the standards.